The reason why I thought I should share with you this topic, I thought it is very important for all of us to understand how we should manage pregnancies with fetal defects. So without wasting much time, I'm going to start now. I hope you can hear me loud and clear where you are. Let me see if, yeah, I think I'm on. So yeah, so fetal defects, this is our cohort, the patient that we see in the fetal medicine unit at Salem Pari. You can see that out of the 9,513 pregnancies that we have seen, we had 176 fetuses with defects. And the total defects number was 340, which makes up an incidence of 2 in 100. That is the cohort of patients we look after in the fetal medicine unit. This is more or less in agreement with the international data, where it is quoted that between 2 to 3% of pregnancies are complicated by defects. So when you look at these defects, you will see that cardiac defects are the most commonest reported, followed by the central nervous system, followed by the face, the renal, and the GIT and abdominal defects, and also the musculoskeletal and the thorax defects, in that order. What does this graph, the pie chart, tell us? What it tells us that we should all enhance our skills to be able to look at the heart carefully, because most defects are on the heart. So if we're not able to look at the heart carefully the way we should, we are more likely to miss these defects. Scanning according to protocol is very important because it improves the detection rate. Some of you will probably be working more or less as independent practitioners now and in the future. It is very important for you to know this. To know that cardiac defects are the commonest defects. If you are not picking them up when you are scanning, or even suspecting that the baby could have a cardiac defect, it just means that you are not doing it properly. If you scan 200 patients consecutively, and none of them you suspect a cardiac defect, then you need to revise your methods, to question your method, to say, are you doing it properly? So that's the trick with the pie chart you see there. To just try and push everyone to say, look, we need to look at the heart carefully when we are examining babies, because cardiac defects are the commonest defects in our cohort. I think those who record the older data, the earlier data we presented, you will record that cardiac CNS defects were the commonest. But we think through the teachings we are doing, and also the presentations we are putting on the YouTube channel, more and more people are becoming aware. So when you try to aggregate the defects, these are the cardiac defects you see there. You can see that there's the different kind of distribution. I'm sorry that the pulmonary hypoplasia was put under the cardiac defects. It's not supposed to be under the cardiac defects here. But we can see that conditions such as tetralogy, VSD, AVSD, if we combine the VSD and we just call them endocardial cushion defects, you can see that they make up the majority of the heart defects. This is why examining the septum is such an important component of your examination. Make sure you check the septum carefully, because that's where the majority of cardiac defects will lie. And then we have coarctation of the aorta, tetralogy, aortic stenosis. then transposition of blood vessels, and the heterotaxis. Most of the ones I've mentioned here are actually outflow tract abnormalities. So knowing how to examine the outflow tracts properly is very, very important. You should know how to look at the outflow tracts to make sure that the outflow tracts are coming out the way they should. You should be able to obtain a V sign, a 3-vessel view, and a 4-chamber view. There are some probably in the audience who may not be aware of the terms that I'm using, like 3-vessel view and 3-vessel trachea view. Please go and watch our YouTube channel, our YouTube presentation on fetal echocardiograph or fetal heart examination. These videos are found on Fetal Medicine Foundation Zimbabwe YouTube channel. So just go there and watch so that you can familiarize yourself with the terms, and probably rewatch this talk again because it's going to be recorded and uploaded to the YouTube channel. Then the central nervous system, ventriculomegaly is the most commonest defect by far, of course, followed by others like acrania. Acrania is the anencephaly spectrum. Then it's the whole spectrum from acrania to anencephaly. So it's more one and the same thing, really. Then we have anode carry. Then we have the myelomeningocele. Anode carry and myelomeningocele, again, let me say they are one and the same thing because they one lead to the other. So, yeah, so let me say these are after ventriculomegaly, the spine defects are probably the most commonest. Acrania and spinal defects are the most commonest. All these banana, lemon head, I think they are all one and the same thing where we have a spinal defect. So what does it mean? What it means is that measurement of the ventricles is something that we should all learn to do consistently. There are no shortcuts when it comes to measurement of the baby's ventricles. Please know how to do them properly. If you don't know how to do them properly, go to our YouTube channel and watch the talk on central nervous system examination or a neurological examination. One of them, I'm forgetting the title, but it should be CNS examination. It's again available on the YouTube channel on Fetal Medicine Foundation Zim on how to measure the ventricles, the baby's ventricles, brain ventricles properly, so that you can increase the detection rate of ventriculomegalies. Ventriculomegaly is very common in fetal medicine terms. It's as common as 1 in 100. So if you scan 200 to 300 patients consecutively and you have not suspected even a single case of ventriculomegaly, then you need to revise your ways and look carefully and say, where am I going wrong? This is very important to do because if you want to stay at the top of your game in clinical practice, you always have to reflect on your work. Reflection is an important part of you staying at the top of your game in any form of clinical practice that you embark in. You should reflect and change your ways or improve your ways of doing things. The same thing with the spine. Believe you me, most spinal defects we pick are actually missed. Babies are referred with what will be suspected as primary ventriculomegaly, when in fact what they will be having is secondary ventriculomegaly due to the myelomeningocele. What does it mean? Why are they being missed? They are being missed because the spine is not being examined as carefully as it should be. Always remember that the spine is examined from the occiput, where it attaches to the baby's head, all the way up to the tip. And the skin should be seen, and the spinal bones should form 2 continuous lines, look like a railway line, all the way up to the tip. That's the proper way of examining the spine. The rest of the other defects, some are pretty obvious. in terms of seeing those, the holoprosencephaly. Some of you have managed to pick up the holoprosencephalies and so forth, which is a good thing. There are some defects which I can see missing here. For example, the hydrancephalus, all those, we've come across those patients, but sometimes in terms of the data harvesting, I think some information may be lost. Kidneys. What is common? What is common in the kidneys is the hydronephrosis from our database. You can see that hydronephrosis is very common, and the hydronephrosis cases require everyone to be able to measure the renal pelvis. The renal pelvis should always be assessed when you are doing an anomaly scan, when you are scanning the baby for the very first time. In fetal medicine, the major organs should be checked, irrespective of the gestation that the patient is in. If the woman comes at 40 weeks, you are not going to skip examining the head. All you are going to do is you say you want to measure the BPD and the head circumference and not measure the ventricles. So that means you are going to miss ventriculomegaly on that patient, unless if the patient has been scanned properly in the unit. Then in that case, you'll be saying, look, the baby's brain has been changed, but it's always good to double check. So that means everybody should be checked the major organs, every baby, to make sure the head is normal, the heart is normal, the kidneys are normal, and the spine is normal. All the major organs have to be checked, irrespective of the gestational age that you have seen the patient. Please desist from the habit of saying that all I want to do is to measure and to have the weight, because it's a habit which can easily creep in, and people can deteriorate along that habit or grow in a negative way, because there are two kinds of growth: a positive growth or a negative growth. Positive growth, that means you improve yourself and begin to check more and more and more. Negative growth, that means negative growth, that means you are deteriorating in terms of, you are now taking shortcuts, you are no longer doing the things that are necessary, you are deviating from the protocol. So the most important thing is to stay consistent and to improve in a positive way. That means if you are now able to do biometry, please do more. You cannot just be content just doing biometry on a patient. Do more. Start measuring the right parameters, the kidneys, the renal pelvis, so that we can improve the detection rate. There's a question on the chart. I think we'll answer it right at the end. I'm going opposite, huh? Sorry, my computer is just misbehaving. I'm supposed to go the other direction. Right. So the renal defects, we have touched on that. Then the facial defect, the cleft lip and palate, the hypotelorisms, and also the other defects you can see here, from the micronathia to the hernia, flat nose, flash forehead. Then let's proceed. Then fetal ascites on the abdomen. Then we have exomphalos and gastroschisis. All these are the defects that we coming across in the unit, and the esophageal atresia. Most of these defects, I think they are pretty straightforward, especially the ascites. I think none of you can miss an ascites. Even the duodenal atresia, I think we've seen people picking up the double bubble sign, which is very good. The gastroschisis omphalos, as long as you are checking the umbilical cord insertion on the baby's tummy, these defects are difficult to miss. Sorry, exomphalos and omphalos is one and the same thing, so I was supposed to put here. It was the most common defect in our unit, really, together with ascites. The musculoskeletal system, I think we have the cystic hygromas, which don't really fit nicely there, but kyphoscoliosis was the commonest. And then we do have the rest like clubfoot, webbed fingers, the achondroplasia, the arthrogryposis, the thanatophoric dysplasia, the achondrogenesis, and the rest of the abnormalities. Then the thorax pulmonary fusion and also the diaphragmatic hernias. We did have some cases there. Right. So the global trends, when you look at the global trends here, we see that in countries where there is improvement in clinical care, the contribution of fetal defects as the cause of under 5 mortality increases. So sometimes we may think that the fetal defects are not contributing a lot to the mortality of babies because the other causes are still high in our environment. Because I think we fall somewhere here on the second on the second graph here. That's where probably Zimbabwe is, where congenital defects may probably contribute 8% to our perinatal mortality, but in countries where they've managed to lower the other communicable causes of under 5 mortality, you can see that fetal defects contribute to 30% of the deaths. So this is very significant. This is why prenatal detection of fetal defects is very important, because when everything is okay, in people probably who may not suffer from all these other complications, because even in a population, any population, you will find that there are people whose health profile mirror the first world health profile, because they will get every kind of care they need. They will go to the best hospitals in the country, and they'll get the best medicine that is available to make sure their babies do not suffer from all these other causes. Yet these kind of people will fall into this category whereby fetal defects may be the major cause of why their baby is likely to die before they are 5 years. So this is why picking up fetal defects is very important when you are scanning patients. This is why you should never take your examination of the babies for granted. Please never take it for granted. Never assume that babies are normal until you have thoroughly checked the baby and made sure that they are as normal as they should be, because it really matters. Then the question now is, what is the approach to fetal defects? The best approach really will be the first step will be to do the preconception optimization of pregnant women, of women who desire to be pregnant. That's the best approach when it comes to fetal defect. That means, what does it mean, preconception optimization? There are certain conditions or certain medication that will increase the likelihood of fetal defects, or a certain kind of unions or marriages that will lead to increase chances of having a baby with a fetal defect. So the desired plan is for couples to visit their obstetrician early, or the fetal medicine early, and be assessed for the potential risk of having a baby with a fetal defect. This will allow the changing of medication for those who are on medication. I think we are aware that we've seen some patients who recommend on medication that is not good for the baby before they were pregnant, and they will come later on already having problems of certain organs because of the medication they are taking. So preconception optimization is key when you are approaching fetal defects. Then for women who have conceived, early pregnancy screening is necessary. It is better to detect certain defects early than to detect them later. For example, it is better to pick up holoprosencephaly and anencephaly at 12 weeks than to pick them at 30 weeks like we are doing. Well, this will allow for early pregnancy termination for those who choose that option. But for women who will not choose that, then it will allow them to temper their expectations of how the child will fare after birth. Then we have mid-trimester pregnancy screening. This is the 20 to 22 weeks anomaly scan, which all of you are familiar with. Every woman should have an anomaly scan because fetal defects are as common as around 2% in any pregnant population from many studies done throughout the world. So that means there is no one who is safe. There are no particular group of women you would tell, you do not need an anomaly scan. This is the message that we have to emphasize to every pregnant woman that we manage to influence. For those who are in teaching, please teach this to your students. They should be aware that every pregnancy should be subjected to an anomaly screening in mid-trimester. That is between 20 to 22 weeks as per our recommendation. This is very important. Then for the babies who unfortunately end up with a defect, what is the approach? The most important step is to get a correct diagnosis. This is very key because the conditions differ, the outcome differs, the management plan differs. It depends on the condition that the woman has, the baby has. So getting a correct diagnosis is the first step. So the diagnosis has to be correct in terms of what is it that the baby has. So that means if the patient is scanned at a lower center, the patient should be referred to a higher center for confirmation of the diagnosis. For example, a patient scanned at a district hospital, people cannot manage based on the scan done at the district hospital for a fetal defect. The patient has to be managed, or a higher center has to be consulted before a pregnancy defining decision is made. This is very important. I want to repeat it. So if a lower center makes a diagnosis, that's not the working diagnosis that should be used to manage the pregnancy. When it comes to fetal defects, decisions that affect the pregnancy should be made at the highest center available in that country. So that means decisions on how pregnancy with fetal defects should be managed can only be made in the fetal medicine unit and nowhere else. That is what it means. Because there's a potential for a wrong diagnosis to be made when it comes to fetal defects. And babies who should live may be terminated, or babies who probably have no chance to live may be recorded as having a chance to live. And this will affect the couple one way or the other. So please get this right. I'll just repeat it the third model, the third time. So the diagnosis or the decision that defines how a pregnancy should be done, should be managed, should be made at the highest center available where you are working. If you are in Zimbabwe, then the patient should be referred to the fetal medicine unit, or the fetal medicine unit should be consulted one way or the other. Nowadays, the good thing is that there is video, there are videos, there's Zoom, there's also an opportunity to do telemedicine. A consult should be made before a pregnancy defining decision is made by the couple. So confirmation of the correct diagnosis is important. Then after the diagnosis is confirmed, then they follow the care pathway. This is to just show you the detection rate of fetal defects based on the gestational age. So the ability to pick up defects is about 45% if we do the scan at 11 weeks. But you can see that there is an improvement towards 14 weeks. Marked improvement. Actually, it gets to 75% if the scan is done at 14 weeks, close to 14 weeks. So what does this mean? That means if the purpose of seeing the patient again is to screen for recurring fetal defects, the best time to see this patient will be in the 13th week, because you are more likely to see more clearer and much better if we see the patient at this time than if we see them at the 11th week. So the 11 to 12 weeks is not the best time to screen for anatomical defects on the baby. The best time will be 13 to 14 weeks. But we have to balance it with the screening for aneuploidy, where we would need to measure the knuckle translucency and all the other parameters. And the baby is a little bit more naughty in the 13 week than at the 12 weeks. So this is why we bring them at the 12 weeks here. Yeah, where we have a more than 70% detection rate of certain defects. So remember this, very important. So you can see these are some of the defects we can pick in first trimester, the 11 to 14 week scan. We can pick here the anencephaly. You can see acrania, the brain uncovered there without any cranium around it. Then we have the holoprosencephaly. Then we have the large exomphalos. Small exomphalos, you always have to tread with caution because it could be just physiological. Then we have a large myelomeningocele here. And we have a megacystis, a very huge bladder due to outflow tract obstruction, lower urinary tract obstruction. Then this is the detection rate of the various systems here. You can see for the neck, because of the cystic hygromas and so forth, the detection rate is very high, and the heart is much better than the other systems here. And the overall detection rate is around 50% at the 11 to 14 weeks, which is modest really for such a small baby. Then for the second trimester, this is the detection rate of most defects. You can see for the CNS is above 88%, for the respiratory 70%, the GIT is 53, GUS 84, facial 18, cardiac 38, and musculoskeletal is 73, and A&I 15 and 14. So what does this table tell you? What it tells you is that the detection rate of fetal defect is not 100%. So an anomaly scan can only prove that there are no obvious fetal defects seen on the particular day. But a normal scan does not rule out all the defects, and also does not rule out chromosome, all the other chromosomal and genetic syndromes. This is why we put this statement in our report of the anomaly scan, because this is what we know about the detection rate of fetal defects, even in the base of hands. Because all this study was based on ultrasound done by certified performers of anomaly scans. These are people who are certified, who do it according to protocol. We have done it many times, and this is the detection rate of defects. That means there are certain defects that may be seen on babies after birth that were not picked up in uterus. So remember this, because if you don't remember it, you may surprise yourself when you see that there are certain defects that you didn't pick in uterus. There are some which should be picked, then there are some which are extremely difficult to pick in uterus, and the patient should be aware of this. You should make the patient aware that not all defects can be picked in uterus. Then what causes fetal defects? Most fetal defects are actually multifactorial in the general population. If we go into the general population, most fetal defects are multifactorial. That means we will never find the cause why they are there. It's only 1% of the fetal defects are due to chromosome abnormalities. Then The other 1% is due to micro deletions and micro duplications. And the other is due to gene disorders. That is in the general population. However, in malformed fetuses, where there are defects, 25% of the defects are due to chromosome abnormalities such as trisomy 21, trisomy 18, trisomy 13. That is 25%. Then the 8% are due to submicroscopic abnormalities such as microdeletions and microduplications. Then 10% are due to single gene disorders. So that means close to 40% of defects, we may find what the underlying cause is. But 60% of them, we may never find the cause. This is where the multifactorial issues come in here. The question now is, how come we only test for chromosome abnormalities when you know that the other 18% is due to the causes that we will not pick when you do the conventional karyotype? If you do conventional karyotype, you're not going to pick the submicroscopic abnormalities, the microdeletion duplications. The same way with conventional karyotype, you're not going to pick the single gene disorders. The question is, what test then should we be doing? For chromosome abnormalities, it's easy. That's the karyotype and also the microarray we can do to pick up conditions such as trisomy 21, 18, and 13, and other trisomies. The targeted test, if you think the baby has got Downs and you just want to rule out Downs, you do a targeted test, which is qualitative fluorescent PCR or a FISH, although most people are facing FISH now, it's obsolete in some cases. This is more like a targeted test where you just want to know, is there Downs or no Downs? But if you want to start the chromosome number 1 to number 2, XY, then you have to go to karyotype where all the chromosomes from number 1 to XY are going to be studied. Then for submicroscopic abnormalities, FISH again can be done for micro deletions and duplications that are known, that are already known. For example, if you want to know, is there 22q11 deletion on a baby with a heart defect, we just do a FISH. This FISH will target the 22q11 region of the chromosomes, and we'll know whether it is there or not, the deletion. Then we can also do microarray to look for duplication deletions, most of where we do not know what could be the we should target. If we have nothing to target, then we do the genome-wide test, which is a microarray, which will look at all the chromosomes from number 1 to number XY, looking for duplications and deletions. So these are the tests. So when we are saying we want to karyotype and microarray, this is what we are trying to do. We are trying to see if there are micro deletions, if there are micro duplications. Please get this right. Then the single gene disorders occur in about 10% of the malformed fetuses. If we know the single gene, we can just target the gene that we are suspecting. Or if we know that there's a panel of genes we are suspecting, we use the gene panel, which can cover 2 to 200 base pairs. But if we do not know the gene, let's say we suspect that there's genetic syndrome because of the multiple malformation the baby has, and we fear that this, if we don't know this syndrome, there is a risk of recurrence the couple has to be aware of. And also, if you want to do a PGT in the future, for example, the couple will say, look, we have had recurrent chromosome babies with defects. Now we want to know what is the underlying problem. This is the test we have to do. We have to do a whole genome sequence, a clinical exome sequence, or a whole exome sequence, or a whole genome sequence to try and pick where the gene abnormality is, so that in the next pregnancy, this couple can undergo PGT, knowing the defect, because you cannot do PGT if you don't know the actual defect you are trying to screen for, because you get a lot of abnormalities which you cannot explain, whether they can be passed on, whether they've come from the parents or so forth. So the clinical exome sequencing is the depth at which most centers are now doing, and this is the level of zooming. Then we'll also have the whole exome sequence where we can look at 20,000 nucleotides, and whole genome sequencing where the whole gene is analyzed. So all these tests are available in other countries, and most of the tests, if we are to do them locally, they are sent abroad. They are not even done in South Africa at the moment. But you should know that this is the depth, because like I told you that there are people who want to receive everything they would get if they were in America. Please don't limit people who have resources, who want to investigate the things that are troubling them in their lives. So we should be aware that these tests can be done. Right. Fetal defects are always classified into three main groups, with the minor defect, with the major defects, which are non-lethal and lethal. If possible, screenshot this slide here, because it will help you as you see patients, so that you do not sort of either give too much expectations or give too unnecessary despondence to the couple. If you pick up, if you suspect one of the defects as you talk to the couple. So these defects are considered minor. These ones are major defects. And these ones, again, major defects, but lethal. Lethal means the baby cannot live with them, or they're incompatible with life. I think you are all familiar with some of the terms here. Everyone who works in the units, you are familiar with the terms that you can see there. So I think I'll move on, but screenshot this slide. It will help you to know where most of the conditions that you may come across are. However, just be aware that on some of these major defects, it's only when they are isolated. The moment there are multiple defects, then everything changes. Here we are talking of isolated defects. So it is very important. This is why I was saying whatever defect has been picked, it should be referred to the fetal medicine unit for diagnosis confirmation and also for pregnancy management plan. If you pick one defect, don't celebrate and say there's only a cleft lip and palate. Refer so that we check and make sure that indeed it is isolated. Because you may not have picked other things, you may have missed that there is also a cardiac defect there. Because the moment we have multiple defects, then there is need to test for chromosomal defects or gene abnormalities or microduplications and micro deletions. Now, how do we approach the fetal defects now? If we suspect that there's a fetal defect, what should we do? If the defect is minor, with no serious disability, sometimes babies may require minor surgery. If surgery is required, then we consult the pediatric surgeons prenatally. Please take note of this. We don't tell women that wait for your baby to be born, then the pediatric surgeons will see you. Then no, they'll go for prenatal consult. The delivery timing is not changed by minor defects. Extra finger, of course, if it is too minor, there may be no need really to refer them. For example, an extra finger, it's not a reason. If it is just an isolated, I'm talking of post-axial here, extra finger. If it is pre-axial extra finger, then in that case, something else has to be ruled out, because it's not normal. It's not a normal variant to have a pre-axial extra finger. Pre-axial, I'm saying the extra finger is on the side of the thumb. That's a pre-axial polydactyly. So if there is no surgery, again, no change in delivery timing,
That means the obstetric team will decide when to take out the baby in this kind of scenario. Then if the defect is major, whether it is lethal or non-lethal, then fetal medicine guidance is what is required here. That means this specialists, they have to follow the fetal medicine care pathway to say how should the pregnancy be managed. The fetal medicine now will take over the care pathway in this case. So if the fetal defect is non-lethal, we offer invasive testing to make sure we rule out the underlying possible underlying causes, which make up 40%, like you saw on the other slide. We want to know, is it non-lethal? Then we offer invasive testing where we can do karyotyping, microarray, or whole exome sequencing, or clinical exome sequencing, or whole genome sequencing, depending on how deep the clients are prepared to pay for, because these services are very expensive. The other ones here, the microarray and whole exome sequencing. If there is an association with another defect, or there is an abnormal result from the test, the outcome is likely to be poor, then we invoke counseling in a multidisciplinary team to counsel the patient on the outcome. If the couple choose to be expectant, fair enough, we support them in their choice. If they are expectant, we offer supportive care. Then we counsel on delivery mode and timing. If the outcome is very poor, we really have to let the patient know that delivery mode may not change the outcome, whether they choose to have a Caesar or an NVD. But if the outcome is poor, we're more likely inclined towards an NVD. We highly recommend the couples to choose an NVD, that is delivering vaginally. Then the neonatal support has to be given for expectant managed couples. Then for those who choose termination of pregnancy, again, supportive care. Then fetal side, if they are above 24 weeks before delivery, will be offered. So that's the care plan of a major fetal defect. Where termination of pregnancy is chosen in lethal, this is for lethal. Even for lethal, we do encourage couples to undergo karyotype, microarray, or whole exome sequencing. Why are we doing this? So that we can address the issues of recurrence. If the defect is due to a chromosome abnormality, normally the baseline recurrence rate is 1%. But if it is due to a genetic syndrome, the baseline recurrence rate is about 25%. So the counseling is very important. The result is very important for the counseling, even if we know that the defect is lethal. We offer termination of pregnancy to all lethal defects, and we also offer them expectant. We do not prescribe to the couple what they should do. We offer them the options, and they choose the option that is comfortable to them. So supportive care is given to all the expectant mothers. That is, the routine care is given, and they are given all the support they need throughout the pregnancy. Then termination of pregnancy, for those who choose termination of pregnancy, remember, termination of pregnancy we are talking of here is that they undergo through the legal paperwork, which is signed by hospital authorities. Then the termination of pregnancy happens. Recurrence risk counseling is done. Then the next pregnancy management plan is formulated, and patients are given the option to have the products of conception analyzed to see if anything else was missed during the pregnancy, so that we can help with the recurrent risk counseling and also the future pregnancy planning. What about the major defects, which is just isolated? Where the isolated defects, where no intrauterine surgery is necessary, and stable and there's no evolution, neonatal and ped-search prenatal consults should be done. You do not refer patients after delivery. You refer before delivery. The delivery should be done at 38 weeks. And the mode of delivery depends on the lesion or the defect the patient has. For example, if the woman has a baby with severe ventriculomegaly and they've chosen to keep the baby, this baby is more unlikely to pass through vaginally because the baby is too big. The baby's head is too big. In that case, cesarean section will be done. The same applies to babies with a very large exomphalos. It's highly unlikely that they'll pass through without injury to the liver, and the liver is in the sac. So these babies may have to be delivered vaginally. But for the rest of the fetal defects, vaginal delivery is not contraindicated. So that for some couple, for some babies, induction can be done in 38 weeks. And the multidisciplinary team should be involved around the delivery depending on the defects. This is why we write the reports the way we write them, where we say neonatology should be present at birth. When the condition is worsening, we have a major defect and there's evolution in uterus, the condition is worsening. Which kind of conditions can do this? For example, ventriculomegaly. Babies with probably with skeletal dysplasias, where the thorax is not growing, it's getting narrow and narrow, but babies with skeletal dysplasias. And also babies with pleural effusion. All these babies have a risk that they could deteriorate. If prognosis worsens, then delivery has to be planned. And sometimes termination of pregnancy can be offered as an option for these babies. Then intrauterine surgery, where intrauterine surgery is done, then fetal surveillance and watchful evolution delivery will be done depending on the condition. Briefly, to just take you through feticide. I think some of you have assisted in the feticide procedures, but what is it? Feticide, basically, we are saying this is the procedure that ensures the death of the fetus prior to expulsion. The indications are lethal defects or major fetal defects associated with disability, or cases of sexual assault, and also severe maternal disease, which compromises the health of the mother. When should it be done? Guidelines such as the RCOG, they recommend that it should be done from 22 weeks onwards. The reason the RCOG actually may cause that to ensure there is no risk of a live birth. That's the RCOG guideline on feticide. This is the guideline for those who want to go into this guideline number 7 on the RCOG, those who want to go and look at the reference. Then the legal permission should always be sought, and intracardiac instillation of potassium chloride or lignocaine is done. I think those who work in the fetal defects clinic, I think you've seen us using both potassium chloride and lignocaine. So that is what we use under ultrasound scan guidance. You put lignocaine in the baby's heart. The acceptance rate is very high. It's quoted as 91% per gram here. Because some people may think it's not common and people don't like it. Actually, patients take it. Our acceptance rate probably may mirror this one. It may not be 90, maybe around 80%. Most couples do accept. There are minimal maternal risk with these procedures, maternal risk with this procedure. This is a procedure we recorded the other day at Sally there. You can see for yourself the needle, that's the needle there. We're putting the baby's heart. Now we are putting the solution. Those who never this position, please look away before this video is over. If you can see us putting this time around, it was KCl. I think we had got a vial of KCl. I think this was KCl. Not sure between KCL and lignocaine. I can't remember what to use, but you can see the needle in the baby's heart there where we are infusing KCL and yeah, then we are now achieving assisto. It's not a nice procedure. This is the bleeding as they need to pass it through, may cause break through some vessels and cause bleeding. Most cases, the bleeding stops on its own, and it's not the mother bleeding. In this case, the baby bleeding here. So, yeah, you can see the heart is already stopped from after injecting the fluid is almost going to rigor mortis. Yeah, then we always check to see if we have, this is the evidence of assist. We have to leave the evidence to say, indeed, you achieved the assist. I think this is the end of my presentation. Thank you for listening. Let me check the questions in the chat box. The first one, I think, was to do with how many days that the exome value, how many days that a baby with holoprosencephaly live. It depends. It depends. Some live long, but they don't go home and be normal babies, unless if the diagnosis is wrong. But if it is proper holoprosencephaly, the majority I've seen within 48 hours, 72 hours, they will have passed on. Unfortunately, that's the answer to that. Then yes, it is necessary to pick a leader defect after 30 weeks so that the couple can choose to keep on, and also that they have knowledge, so that they are aware, they temper their expectation prenatally. Believe you me, it is old-fashioned for people to discover a leader defect at birth, or it doesn't belong to our age, where couples pick that they have a fetal defect at birth. It should never happen that way. Yeah, so it is not normal. Please take note of this. That feticide can be done even as early as 40 weeks. Well, there are some babies who are leader, but like the holoprosencephaly, they will not die immediately. What is going to happen is that parents are going to go through trauma, because the moment they give the baby, it is their baby, and no one will allow them to just leave the baby at the hospital. So they have to look after the baby. 1, 2. The hospital has to use resources on this baby to look after it, because you cannot watch a baby crying, even if they have one eye, like in holoprosencephaly cyclopia. You can't watch this baby just crying. You have to attempt to feed it, whether by giving IV fluids and so forth. So that the same will happen with babies with the other defects. There will be a lot of resources, hospitals that will be wasted, and couples will be made to wait at the hospital, waiting for something that will never go home with them. So that is traumatic. Right, so that is why we still have to diagnose fetal defects in 38, 39 weeks, so that we can offer these couples the opportunity to terminate the pregnancy. Okay, do we have any more questions? Any more questions? If we do not have any more questions, we are going to call the meeting to an end. Otherwise, wish you guys all the best, and we'll see you next week. Please try to identify interesting cases as you are working, so that you can present them at the Fetal Medicine refresher course. So try to identify very interesting cases and share with Thelma all those cases, so that they can be used for the refresher. The second thing is that the UZ Fetal Medicine unit will be opening starting Monday next week. Like we said, that some of you will rotate through that unit, doing scans there. So it will start next week, the Fetal Medicine unit. Thelma will communicate with you most of the details. Otherwise, enjoy the rest of your day, and bye-bye. See you.